Welcome. Thank you for joining us today. Today, we will be presenting to you our integrated care program for diabetes at the Baylor Scott and White Health and Wellness Center. The title of our presentation is Efficacy of Real-Time Team-Based Diabetes Care in a Community Medical Clinic. Thank you for your participation. Our objectives today are to pique your interest in collaborative models of delivering healthcare. Our team-based diabetes care project has shown to reduce A1C versus usual care. We have received 2 grants and published our findings in the Journal of Primary Care and Community Health. We would like to take you through the ICC precepts from inception to implementation. We'll touch on the why, the what, and the how, as well as the outcomes, and then we'll propose some next steps. We've learned a lot from this model, both the tips and the pitfalls. Hopefully, you'll hear something that you can implement or tweak in your various healthcare settings. We'll start with a brief video introduction to the Baylor Scott and White Health and Wellness Center services. This video was designed for our patients and members, but it will give you a good overview of what we offer to the communities we serve.
The places where people live, work, and play greatly impact their health. At Baylor Scott and White Health and Wellness Center, we are committed to improving the health of our city, one person, one family, and one community at a time. Our goal is to improve health outcomes of the uninsured and underinsured by addressing key social factors. These include economic stability, access to health care, neighborhood environment, education, and social and community context. And our opportunities for prevention increase when we work with partners from diverse sectors and institutions. Our center began in 2010 as a partnership to address diabetes. Now we target all chronic conditions to prevent diseases before they start. Since 2010, membership has grown steadily. Today, we improve community health in 3 ways: access to clinical care, access to nutrition and health education, and physical activity. Clinical care is provided by our Family Health Center, a medical home for those who might otherwise use the emergency room and rely on hospital stays as their primary care. We've created an innovative integrated care initiative where members receive primary care and wellness services from several providers during one visit instead of multiple follow-up visits. This cost-effective, efficient approach leads to better communication and a more complete treatment plan. For example, our team-based care has been shown to improve glucose and patient engagement and satisfaction in those with uncontrolled diabetes. For health education, nutrition, and physical activity, free membership at our center includes a baseline health screening followed by year-round support. Members benefit from numerous classes, fitness programs, one-on-one health coaching, and counseling. Access to nutrition is also provided at our 8 farm stands, which are located in food deserts, areas where grocery stores are scarce. At the center of our model is relationships built on partnership, empowerment, support, access, cultural relevance, and trust. To build relationships, we employ full and part-time community health workers to deliver our programs. These workers are front-line, trusted members of the community with a personal understanding of diverse cultures. And we offer multiple places and ways for members to be empowered to live healthy lifestyles. That way, members have programs to get and stay healthy in their own neighborhoods rather than waiting until they are sick to seek care. By integrating individual, community, and environmental factors with access to a patient-centered medical home, we're not only improving health, but also reducing inequities, costs, and unneeded emergency room visits and hospital stays. We've shown our successful outcomes through nationally recognized research. So, with the help of our partners, we're looking to the future. As we move forward, we're committed to innovating and expanding our model to make a difference in even more communities. Healthcare is changing, and at Baylor Scott and White Health and Wellness Center, we are changing it for the better.
I'd like to introduce you to our team. On the panel are Dr. Talabi, our pharmacist, Dr. Lydia Best, our medical director, and myself, Kirsten Robertson, dietitian. Our other care team members include chaplain, community health worker, diet tech, dietitian, medical assistant, nurse, patient service specialist, pharmacist and pharmacy tech, nurse practitioner, physician, and social worker. The role of the dietitian is to provide medical nutrition therapy. During the initial visit, an assessment is completed. The patient's barriers to change are assessed. Individualized education is provided, and the patient is encouraged to set a behavior goal. Progress is evaluated at follow-up visits, and resources are offered based on patient's need and interest.
The medication management team is composed of 2 full-time pharmacists and additionally 1 full-time tech in the clinic. We do complete many things inside the clinic, but these are our main management tools we use in the clinic. One is medication reconciliation. We do encourage our patients to bring in their prescription pill bottles, and we will compare those pill bottles to the list that they have in their chart and update it as appropriate. We do a lot of medication education as well on new medications or if patients have questions. Also counseling patients on new devices, including insulin or inhalers. We also do a lot of formulary management inside of the clinic. We oversee a formulary and we are able to update this as needed. Any of our patients that have not picked up their medications within 7 days appear on an adherence list, and we will reach out to the patients and make phone calls for them to try to identify their barrier to adherence. One of the most exciting programs our team is able to participate in is disease state management, and we're able to do this through a collaborative practice agreement with our provider. We update this annually and it's signed annually, and it allows us to make interventions for patients. So our patients will bring in, for diabetes, their glucometers. We will take their averages, and from their averages, we'll decide if they need a medication adjustment or if they need a new start to a medication or a decrease, etc. We also do this for hypertension. Our patients will bring in their home blood pressure logs, and we'll be able to take the average of their home readings and make any adjustments that are needed for their blood pressure medications. We also take the blood pressure in clinic as well. We also participate in anticoagulation. We use point of care INR monitoring machines, which work right away, so we're able to get our results right away and make adjustments to the patient's warfarin. And we also assist patients in quitting smoking and finding interventions that really can help them. This is our pharmacy team workflow. So it all starts with our provider. So our provider will identify patients for us that do need help or need our assistance. The next step is us going in and scheduling patients for visits with our medication management team. During our medication management team visits, we will review the patient's home blood pressure readings and also their glucose readings. We'll complete any education that's necessary and also make any medication adjustments. And we do follow up closely with the patient. So we do try to see them every 2 to 4 weeks until they're well controlled with their glucose or their blood pressure.
This is Dr. Best. I'm going to briefly talk about our patient population. So our demographics really reflect the community of South Dallas where we serve. Our founding board member, the City of Dallas, and our Health and Wellness Center chose a city recreation center named after famous civil rights activist Juanita J. Craft, because this area had one of the highest rates of diabetes in Dallas. In 2010, the diabetes death rate in our immediate zip code was almost 3 times the rate of the rest of Dallas County. Our Family Health Center has about 2,000 active patients, 70% of whom are uninsured, and about 95% of our patients are either Black or Latino, and that's split about 50-50, and 44% of our patient population has diabetes. Because of our reputation for comprehensive diabetes care, we receive a lot of hospital referrals for people with long-standing uncontrolled diabetes with A1Cs far exceeding 14. Our standard care model provides robust nutrition, physical, and medical services, but we still see an unacceptably high level of uncontrolled diabetes in our patients. Our goal is to have less than 35% of our patients with an A1C above 9, and we were not meeting that metric. Perhaps it was due to clinical inertia or barriers created by multiple visits or competing interests. But as late as 5 years ago, our services were co-located but not coordinated in time or space. Here we see the ADA recommendations for when a patient is not meeting goal. We were doing a lot of these ideas, but I've highlighted some that are the gaps that we closed by adding ICC or integrated care to our usual care model. So ICC is our vehicle for co-managing patients with the diabetes team to increase patient contact among the various clinicians. So we began researching integrative care models, and we found very little outcome data. So we decided to explore some ideas and assess our own outcomes. In 2016, we piloted a shared medical visit. This pilot helped us learn what components of integrated care were most important to our patients. After that, we introduced clinic hours for our dietitians, and it seems that meeting the educational staff in a familiar environment seemed to increase patients' comfort level and their utilization of education services like diabetes self-management. This led us to explore ways to fully collaborate and co-manage the care of our mutual patients. Here we see what we found to be the key ingredients for integrated care. It should be patient-centered, not physician-centric. It should be collaborative, not physician-centered. Did I say that already? If we look to the physician as the final authority, we'll never get to true collaboration. We have to sit at a round table with shared decision-making. Each component must have equal weight: education, counseling, and medical treatment. One modality might take precedence for a given patient in a given week, but in practice, all contributions have to have equal value. If this sounds unrealistic, we know the studies show that what happens in the standard exam room only accounts for about 20% of a patient's overall health. We could see this in our patients as well.
The aims of the Integrated Care Clinic are to improve population health outcomes, increase workflow efficiencies, and improve patient and employee satisfaction.
Now we will start the design portion of our presentation. We included patients with an active diagnosis of diabetes with an A1C greater than 8 or a BMI greater than 30. All patients also had to be patients of Dr. Best. We had 3 different ways of selecting patients, either through a clinician referral, a chart report based on inclusion criteria, or letters to all eligible patients. Initially, we sent invitation letters to all eligible patients with uncontrolled diabetes from our clinic registry. This was a low-yield endeavor, and we don't recommend it as a sole source for referrals. Instead, our patient referrals come primarily from the clinicians themselves. We had to train our team that any clinician could refer a patient into the program. The work that goes into planning the ICC day includes monthly committee meetings, inputting our data and analyzing it, and purchasing snacks and certificates. Each week we do a huddle on all the patients. During the weekly huddle, we review barriers, goals, and discuss treatment plans. We use a laminated welcome form that we give each ICC patient so they can list their concerns with each clinician. The patient can also ask for the chaplain or social worker since they aren't in the regular rotation for ICC, but they do make themselves available as needed. So what does a typical ICC clinic day look like? It starts with 4 patients arriving at 1 p.m. They complete the welcome form, any lab draws, and the MA downloads the meter and prints a report of the last month's readings. At the same time, the rest of the care team huddles for 10 to 20 minutes to discuss the goals and patient progress. Patients receive comprehensive, same-room, multi-provider care. Each clinician will visit with the patient for 20 minutes, including the primary care physician, LVN, pharmacist, dietitian, our diet tech, and a medical assistant. The social worker or the chaplain are available as needed. The diet tech has the honor of giving the snack, so patients like seeing her early. If we do it right, the patient has very little downtime during their visit. It takes communication and coordination. Lastly, if the patient has a metric that they have achieved, we will do a celebration. The whole team goes in with bells, a certificate, and there is singing and clapping, a speech from the diet tech, and a few tears.
New patients receive a welcome bag with incentives, such as a pill sorter and other goodies, and information on wellness programs and physical activities available at no cost at the Wellness Center. They may sometimes receive a produce voucher to our weekly farm stand to purchase low-cost fruits and vegetables. Now we will discuss outcomes. When we developed ICC, we had 12 metrics in mind. We are tracking all except those listed in red. Currently, we track A1C control, blood pressure control, BMI improvement, self-monitoring of blood glucose adherence, self-reported physical activity, class participation, and patient satisfaction. When our membership and pharmacy systems are integrated, we will also be able to efficiently track the metrics in red.
We started ICC in 2017 and paused for 2 years due to COVID. We just rebooted about 6 months ago. This you see is a snapshot of our 2022 ICC participants. The active column on the left are those that completed at least 2 visits. The inactive column are those that came for an initial ICC but decided to return to usual care. We're using them as a comparison group. Both groups, as you see, had very high A1Cs at their initial visits. The BMI was slightly higher in the active group. The blood pressures were similar in both groups. The average number of visits for an active patient was about 4 or 5. And by definition, the inactive group only completed 1 visit. Next, you'll see some outcome data on self-monitoring. Overall, I'd say the results show no correlation to participation in ICC. Self-monitoring is credited only if a patient brings their meter to the visit and they have at least 3 readings a week. Many patients indicate that they forgot to bring their meter, which might explain the inconsistent results here. Likewise, the physical activity seemed to vary without respect to ICC. Physical activity is self-reported, making those results also unreliable. We do see that ICC patients elect to participate in a few more classes, but the overwhelming majority of our patients have completed at least 1 class outside the clinic in our wellness center. One of the 7 metrics that we can objectively measure include the A1C, the BMI, the blood pressure, and we can see that an active participant has improved almost twice as many of those metrics as an inactive patient. The active patients have improved their A1C by about 76% and their BMIs improved by about 65%. And we're excited about this metric because previously the BMI hadn't shown much improvement. We think it was due previously to the weight gain from insulin titration, but now with better patient assistant program access to diabetes medications that have been proven to reduce weight, we see a beneficial effect on BMI. This graph here shows the active patients in blue with net decreases in blood pressure, BMI, and A1C. The inactive patients in red, for the most part, remained about the same or increased their metrics. So as I said before, we paused ICC from 2020 to July of last year, but patients still received their usual care. So we wanted to know if ICC improvements were sustainable after a patient stopped the program. So that pause gave us that data. We can see that the 1.5 percentage point improvement was well sustained during that 28-month pause. This graph looks at A1C as a function of the number of ICC visits. Though we don't see a linear association between the number of visits and A1C, we do see the A1C trending downward as the number of ICC visits increase. The reason that this drop is not linear may be because patients with worse control require more visits, Or some patients are inconsistent with their regimen, stopping and starting medication or education or their exercise regimen.
In addition to the work that we're doing with ICC, we also see patients for diabetes management that we had mentioned earlier in our slides. Currently, we have 144 actively enrolled patients. Our initial A1C for most patients starting is around 10.7%, and we're seeing a post A1C of 8.2%, which is around a 2.5% reduction for all of our patients that are enrolled in diabetes management.
In 2022, we published our pre-COVID ICC data in the Journal of Primary Care and Community Health. Overall, comparing 56 patients, we saw a statistically significant decrease in A1C in the ICC group versus the control group. The average A1C reduction was 0.96 in the ICC group versus 0.05 in the control group. We further broke down the participants by demographics and found that females and Hispanics had a statistically significant decrease in their A1C, while African Americans showed a decrease, but it wasn't statistically significant at 0.83. Now I'd like to highlight some of the grants and awards that our Health and Wellness Center has received. We achieved target recognition from the American Heart Association and American Medical Association for blood pressure at the highest level of Gold Plus, also Participant Award for Diabetes, and High Achieve Award for cholesterol. We also were awarded 2 research grants from the Agnes Kluth Oliver Foundation.
Here are some lessons learned from implementing ICC. Initially, we had a rigid schedule to follow for rotating into the patient rooms, but we figured out that we could go in any order as long as the patient met with all of us. The planning takes flexibility. In terms of creativity, the celebration idea came from a more outgoing member of the team, and the patients love it when we celebrate them. Lastly, we have some work to do in pre-educating patients on this model because some still come in only expecting to see the physician. We know that most visits take an hour door-to-door time, but some patients are hesitant to agree to an hour and 20-minute visit with a rotating team. For example, one change that we did make this year was to give them the snack earlier in the visit instead of on the way out, and this seemed to help.
So we have been discussing next steps, and one of the things we can do is refine our population. So right now we're looking at people with an A1C greater than 8, but also a BMI greater than 30. We might in the future look at the A1C in preference to the BMI. We want to be able to expand our model, either seeing patients more days or having more providers on board with ICC. And lastly, we're talking about graduating patients at 6 months so that a new group can start ICC.
Overall, our patients and our staff are happy with the outcomes of ICC. We see benefits and improvements every year, especially with our patients' A1Cs and class participation. We thank you all so much for your time and attention.